I have no disclosures. Percutaneous endovenous intervention for acute DVT has undergone a roller coaster experience over the last 20 years. And with the publication of the ATTRACT trial, and Dr. Razavi was here, he was one of the authors, it really dropped it to the nadir. But now, as of last year, we have made some progress to elucidate the findings better. It was published in December 2017 after close to 8 years from conception to reporting. And this was the conclusion. It says amongst patients with acute proximal DVT, addition of intervention to anticoagulation did not result in a low risk of post-traumatic syndrome, but did result in a higher risk of major bleeding. So whoever reads this in the New England would say, well, this is not the proper way to go. And actually, this was not the judgment of lay people, but physicians in Europe specifically. They came up with editorials about this and said that just how attractive is the ATTRACT trial. In our opinion, for the reason described above, it does not reflect our position. And then the authors also tried to explain this further. Then there were more trials, more opinions. Journal of Vascular Surgery opined that the results of the ATTRACT trial after this 8 years do not change the management of acute DVT. Then people started looking at it more carefully, and recently in February 2019, Dr. Camarota, one of the other authors, looked at the iliofemoral component of the ATTRACT trial. But let's see what happened. This was an NHLBI phase 3 multicenter trial. It was open labeled. 692 patients were enrolled. It was to address PTS, quality of life, cost effectiveness, and symptom relief. The inclusion and exclusion criteria were broad, but out of over 28,000 people who were screened, over 26,000 were excluded, and only 692 underwent randomization. 62% were male, age was young, around 50, 25% had history of previous VTE, and 57% had iliofemoral DVT. They were randomized. Firstly, they were divided into iliofemoral and femoral popliteal, and they were randomized to catheter-based intervention plus anticoagulation and anticoagulation alone. The primary efficacy outcome was post-thrombotic syndrome defined by the Vialta score of 5 or above. And if they had venous ulcers, they were categorized in the same class. Secondary endpoints were how severe was their Vialta score and its assessment of PTS by VCSS score, and also whether their leg pain and swelling improved, and what was their quality of life. The two instruments which were used for quality of life were SF-36 and the Veins QOL. The quantification of thrombus was independently performed by the Marder score, and the dose of TPA which was utilized was around 20 milligrams, and the duration was about 20 hours. Now, what they found was really the binary definition of PTS wasn't changed. In other words, 47% in the interventional group versus 48%. And major bleed was 1.7 in the interventional group, 0.3, and this was barely significant. So that is why the opinion was driven that this was a negative study. But look at the Vialta score. There are 5 symptoms and 6 signs. The signs, you can use this acronym, PEPSI with an E at the end: pain, edema, pigmentation, skin induration, erythema over a varicose vein, to remember that. And if somebody stands here if I fly from Phoenix and come and stand here for 20 minutes, my Vialta score would be probably around 5. So I would be having post-thrombotic syndrome here. So that definition, I think, shouldn't have probably defined for this study. If you look at the outcomes, moderate to severe PTS was significantly less in the interventional group. Recurrent VTE and death was not significant between the two groups. So there was no difference in primary endpoints. There was an increase in major bleeding, but moderate to severe PTS was significantly less. And if you look at the SF-36, there was no difference in quality of life. But is this really what happen? If you look at the most important component, which is the iliofemoral DVT, there were 391 patients, and they were also randomized. And you would see that although the total Vialta binary score did not differ, but major bleeding was not different either. And if you look at the VCSS score, there was significant reduction in the post-thrombotic syndrome in this group. And if you look at the overall severity of the PTS by Vialta score and VCSS, for both definitions, there was a significant decline in favor of intervention. Also, moderate to severe PTS was reduced, severe PTS was reduced, and severe PTS defined by the VCSS score was reduced as well. If you look at the leg pain, there was significant reduction in favor of intervention, leg edema as well. The SF-36 quality of life instrument was negative. In other words, it did not show any physical or mental benefit. But if you look at the veins quality of life, which is more important in these people, both the overall score and the symptom score was in favor of intervention. Recurrent VT was not significant between the two groups. And the ATTRACT trial, the summary of this would be that if you look at interventional group, it did not reduce mild PTS, but it did reduce all PTS. If you look at the VCSS score, its significant reduction was noted, pain was reduced, edema was reduced, and the quality of life was improved. However, the recurrence of VTE was not different between the two results, the two groups. The limitations was that 23% of the interventional group and 33% of the control group did not get assessed. There was variation in the anticoagulation regimen between centers. They used the binary PTS definition. No IVUS was used. The concept of 50% narrowing on venography was utilized to define stenosis. Sometimes you see normal venography, whereas you still have significant stenosis, and the mean pressure gradient, as Dr. Azavi pointed to, is not very accurate. So in conclusion, intervention can be considered in patients who are young, have iliofemoral DVT, who are symptomatic, and have a low risk of bleeding. So the take-home message is for those people who are doing intervention, for such people, keep doing it. For those who are not doing it, start doing it, and we would like to avoid misleading inferences, and as it is common these days, we don't want fake news. Thank you.